in Eagle, Colorado in the fall of 2016. At that time, that was under the management of Augustana Care. And just an update tonight, Augustana Care and Elam Care, both Minneapolis-based nonprofits, voluntarily joined together in 2018. They affiliated to form a new company called Cassia. So just an updated piece of information for you. Castle Peak is now owned and managed by Cassia. And from a position of strength, reinforcing both organizations' missions and increasing the number of people we can serve daily, this affiliation with over 200 years of combined experience augments our service to people by focusing on resident, patient, and client care. Note on the slide that Cassia offers senior living and care in 5 states, Minnesota, Iowa, North Dakota, the beautiful state of Colorado, and Florida. And you notice the levels of care there that are offered. Thank you. Additionally, Cassia has many service lines that complement our senior living side of the business. These service lines help us to serve over 23,000 people per year through hospice, home care, pharmacy. We're really moving aggressively into assistive technologies, medical supply, and rehabilitation services. To learn more about our senior living, senior long-term care, and the other service lines I've mentioned, please check out our website at cassialife.org. Next slide, please. And a little bit about Castle Peak. We currently have openings in assisted living at Castle Peak in Eagle, Colorado. We have strict protocols, and we want you all to know that it is paramount for us to keep our residents and staff safe. We are currently testing staff for COVID once a month. At this time, per the state of Colorado, there is no communal dining. We have just reinstated with social distancing activities for our residents. Church services are offered right now virtually. And at this point, we're also doing our admissions outside with social distancing prior to move-in. To learn more about Castle Peak, please check out our website at castlepeak.org, or you can call our Director of Admissions, Rand Conroe, at 970-989-2500 that you see on the bottom of the screen. He is the Director of Admissions and Marketing. Thank you so much for listening. And at this point, I think I'll turn it back over to Leslie and Dr. Braxton. Thank you so much.
Craig, I've got a quick question for you. Thanks for that.
Yes.
And Rand, I'm sorry about your voice, but don't you all also have like an acute rehab possibility for post-op patients over at Castle Peak?
We do, yes. Yeah, we see a lot of referrals, and we certainly do.
Great, Leslie?
All right, Dr. Braxton, if you want to get started, again, if you guys have any questions, please feel free to use the chat line and we'll do our best to answer questions.
Hey folks, I've always wanted to say this. Hey, all you cool cats and kittens out there in virtual land. This talk is going to really encompass some of the minimally invasive treatments that are alternatives to opioids. And when I came up through training, we looked at the vital signs like temperature, blood pressure, heart rate, and added a 5th vital sign called pain. And we came up with this scoring system called the visual analog scale. And if pain was elevated, we were told and instructed to give narcotics. And told that if we gave narcotics for pain, especially oxycodone or hydrocodone, that the risk of addiction was minimal, if anything. We're finding that some of that is not actually true. And before COVID became the disease that everybody worried about and talked about, it was really opiate addiction. And here's just a map, a little bit more complete map than the Castle Peak one, covering the United States, that shows different hotspots and areas where there are large numbers of opiate deaths. And these numbers have quadrupled since 1999, and it's become a serious problem. It's not a global problem though, because most of this supply of pharmaceutical narcotics goes to the United States, and I don't know if that's partly a cultural thing, or access to care, or intolerance for pain, especially surgical pain. When I worked in Afghanistan with the military, I would give, our soldiers would be in a lot of pain, would give them a lot of narcotics, but actually for the same operation, a local person at local Afghan National Army, Afghan National Police, they would just want Tylenol. So it is a particularly U.S. problem. And of all the overdoses, 61% of them are from opiate related. And this is older data in 2014. That number is more than doubled in 2019. So as a result, our lawmakers and folks are kind of really making it more difficult, partly justified, to prescribe opiates. So you may find it's harder and harder to even get opiates out there. There's a 7-day limit for prescribing the first prescription, with exception for cancer pain or hospice type care. All the prescriptions are logged in a prescription drug monitoring database that we need to check. And then if you're going to do it more than that, it really needs to be under the care of a physician that specializes in this area. And unfortunately, there's not many of those types of people specializing in that area in the Eagle Valley or in Summit County. And so I think it's time we start considering alternatives to opioids, and maybe talking about a few less invasive things that can be done to treat chronic pain. And chronic pain is any pain that lasts more than 3 months. Some folks say it lasts more than 3 months. I think certainly any pain that's going on more than 6 months really should be addressed by a doctor and possibly be considered for a procedure, okay? So the type of pain that we're going to be focusing on is neuropathic pain. That's nerve pain. That's like a toothache that radiates throughout your body, and that's different from mechanical pain. Mechanical pain might be the kind of pain that you get in your knee or your hip from arthritis, nociceptive pain that's from rubbing. But nerve pain is a particular interest that I have as a neurosurgeon, okay? So when we're assessing pain, there are different types. And remember that your doctor can't feel your pain. We have empathy and compassion for you, but you really need to speak up and really do your best to describe it. And some of the questions we may ask are you unable to do basic chores around the house? Are you having difficulty being productive at work, playing with children or grandchildren? Doing activities that the mountains offer, like hiking, biking, or other things such as crafts or gardening, or even being intimate with your partner. And if your pain is limiting you from that, that is pathological, and that's something that we may be able to help you with. The types of therapies out there are narcotics that we talked about, physical therapy, spinal fusion, nerve blocks, and NSAIDs. And if these things are not working, there is a new generation of techniques and modalities designed specifically to treat neuropathic pain, and I'm going to talk about a few of them. They include radiofrequency ablation, burning a nerve that's causing pain in an abnormal nerve, a minimally invasive decompression to decompress or take the pressure off the nerve, or even modulating the nerve with spinal cord stimulation. So let's talk about RFA, or radiofrequency ablation. So it's the application of heat, similar to what's like in a microwave. We generally heat the area to about 80 degrees for anywhere from 1 minute to 3 minutes. It's an outpatient procedure. The electrode is targeting the area that is causing your pain, and most physicians figure out that area by first injecting it with a test dose. So the test dose sees if you respond to that area, if that's a nerve that's abnormal, and then your physician will maybe go back in there, target that nerve with X-ray guidance, and try to burn it or ablate it. It's not just for the back, it also could be done for neuropathic pain in the hips, knees, or even in the SI joint. These are peripheral nerves. They're not nerves within the spinal cord. So it's an ongoing treatment. It's a management of your pain. It's not a cure for your pain. And the results on average last between 6 to 12 months. But that could mean 6 to 12 months of having decreased pain, being more active, more functional. And that's kind of what our goals are. I want to talk about minimally invasive decompression. A common condition I see, especially in folks in their 6th, 7th, and 8th decades of life, is spinal stenosis. And spinal stenosis has a very particular calling card. And what we see is patients will have difficulty with walking and standing, and relief with sitting down or leaning forward. I always joke that, you know, I can pick out people with spinal stenosis when I go to Walmart, because you can see people hunched over the shopping cart trying to get relief from burning pain in their back. And this is something that's a reversible nerve pain, and it generally can be treated with an outpatient surgery. So what's going on here is, if you look at the healthy spine and cross-section, you can see the nerves have a lot of room. But over time, the ligaments thicken, the arthritis gets larger, and it becomes redundant, and it can put pressure on your nerves. We call this pressure stenosis. So when we find a stenotic lesion, utilizing a microscope and a minimally invasive procedure, we can actually drill that open and open that up. And oftentimes patients will feel better within a few days to a few weeks right after the procedure. And this is usually a durable relief if the problem is indeed central stenosis. If the problem is something else, like a facet, it might require a different type of procedure. But if it's really from stenosis, and I'll really question my patients to see when their pain is worse. Is it worse when you walk and stand, or can you hike up hills with no problem, but hiking down hills, it hurts? That sounds like a patient with spinal stenosis and claudication. So this is an example of an operation that I perform personally, where you can see the triangular shape crowding of the nerves, and then just opening up a few millimeters can make a big difference. The technique that I perform is called a laminoplasty or laminectomy. It's a surgery that could be performed awake without general anesthesia, small incision, outpatient procedure, and I decompress the nerves utilizing a microscope. So it leads to a speedy recovery. There is a risk of reoperation, less than radiofrequency ablation, but we say around 30% in 3 to 4 years, especially if the patient has a problem called a spondylolisthesis, where the bones are out of alignment. And your doctor can go into more detail with the risk, benefits, and alternatives of this procedure during an office visit, either in person or in Zoom. Folks often ask, you know, how are you going to do the surgery awake? Am I going to feel anything? Well, the answer is you'll hear things, because because you're still able to hear, but we're blocking the pain with an epidural. An epidural is a commonly performed anesthetic procedure, similar to what a woman going through childbirth might have to relieve her pain during childbirth. And we do this right in the operating room, and it works within a few minutes. During the procedure, I'm able to talk to you, examine you, and make sure that we do the job correctly while you're in the hospital. So we're not calling you back a few weeks or months later saying, oh, we have to do a second surgery. We make sure we get it done correctly while you're there. That's the patient coughing, that I asked them to cough to make sure that everything is freed up. And then I asked them after surgery, So it's really a painless procedure, and we can even do larger procedures like stabilization operations, commonly referred to as fusions. They also can be done awake, and sometimes on an outpatient basis, or sometimes with just an overnight stay. And this was a surgery that I did to stabilize the spine with the long pins or the long screws and rods holding the spine together. And if the symptoms are not relieved with the simple decompression. I think that this awake surgery is associated with faster recovery because you don't have a hangover or the risks of general anesthetics, and it leads to greater efficiency and more respect for the patient in the operating room. In my operating room, we listen to the music that the patient wants to hear, not what I might want to hear or the nursing team wants to hear. So we listen to a wide range of music because I have a wide range of patients. Any questions about the first two topics I had? I thought I saw a few questions pop up regarding radiofrequency ablation or minimally invasive decompression.
I'm looking here and I haven't gotten any questions so far.
Okay, that must mean I'm doing a great job or everyone is asleep, watching football or something. Okay, next thing is spinal cord stimulation. This is a technology that's been around for many years. It's been FDA approved since the 80s, but the technology is constantly improved with generator technology, with different waveforms. There's now even newer stimulators that are MRI conditional that you can get an MRI with, provided it's a special type of MRI that we have at our office or that they have over at Vail Health or at Vail Health.
Dr. Braxton, can I interrupt for just a second? We just had a request to just slow down just a little bit. A couple of patients are kind of trying to investigate your slides a little bit more.
Oh, okay. All right. I'll slow down a little bit. I apologize for that. I see a question. Would you do a decompression if there's stenosis and a I think that's spondylolisthesis. So this is a debate that we have, us surgeons have back and forth. Should we do a decompression or should we just do a fusion? And my belief is it depends. If most of the symptoms are in the legs, and if there's no movement on the spondylolisthesis, I feel that it's very reasonable to do a decompression. If most of the pain is in the back, and if most of the and if there's a lot of movement or sliding back and forth, then I think that the patient's more favorable for a fusion. So, but the way I truly decided is I try to lay out the pros and cons of each path that we take, and we decide together. I make the suggestion, but we decide together. And some folks, even though I think maybe they might be a better candidate for a fusion, they'll say, I really want to try the decompression. And we'll do the decompression, and sometimes it works, but if it doesn't, we understand, and we can always go back and do a fusion later. You can't do it the other way around. So this talk is being recorded, and we will post this on our Facebook website and LinkedIn and Instagram and all the social media, so you'll be able to go through it in more detail later on in the future. Okay, I'm going to talk a little bit about spinal cord stimulation, unless I have any more questions about decompression or any more questions about radiofrequency ablation. The Facebook page, we will get a link out to the Facebook page. It's the VS Ortho, Vail-Summit Orthopaedics page. It's our main page. It's pretty easily searchable. If you just type in Vail-Summit Orthopaedics and Neurosurgery, it will come up. And give us a couple days to get that on the website. It just takes a little while to process and edit the video down. So it may take a few days, but we will certainly get that on there. Okay? I'm going to close the chat and ask Leslie to ask questions. All right. So who can benefit from spinal cord stimulation? The interesting thing is most of my patients have never heard of spinal cord stimulation when they come into my office. It's the first time they've ever heard of it, which I think is a shame. They've heard of other procedures like fusion operations or decompressions or a back injection, but they've never heard of a spinal cord stimulator. It's for nerve type pain, not mechanical pain, but nerve pain. It's that pain that feels like a toothache when it goes down your leg or goes down your arm or goes down your, or radiates around your back. It feels more, the best thing I could say, it's like a toothache. And it's usually for patients who have neuropathy, a disease called CPRS, which is complex regional pain syndrome. Sometimes a failed back surgery. If you had a back surgery by another doctor or even by me that didn't work, a stimulator might be another option. If your pain is on average 5 or greater, that's a subjective, but we think of 10 being the worst pain and a 1 or 2 being not so bad. And if the pain has lasted more than 6 months, you may be a candidate for a spinal cord stimulator. It's not for somebody who, oh, I did a lot of yard work this weekend, or I went hiking and now my back is sore. We let that rest. We try physical therapy and maybe some Tylenol or Motrin. We don't go right to surgery. It's got to last more than 6 months, in my opinion. And it needs to have failed physical therapy, injections, maybe even radiofrequency ablation, and you still have pain. Spinal cord stimulation is often considered when medications or surgery are not an option. And sometimes I'll have a patient with a structural problem that would love to fix, but their bones are so soft and osteoporotic that I don't think a surgery would be safe for them. And then maybe their option might be a spinal cord stimulator. This is approved for back pain, leg pain, or foot pain. It's currently not FDA approved for neck or arm pain, and we're going to talk about mainly indications that it's FDA approved for in the United States. In other countries, they may use it for other things, but in the United States, it's for back and leg pain. Am I going too fast, or is that speed a little bit better?
I think the speed is a little better, and we do have another question. We have a patient here that has had issues with her lower lumbar spine, L4 and L5, but is having some excruciating pain between shoulder blades. Could this be a result of that lumbar pain?
Usually not. Usually not. I don't want this patient out there to be offended, but that patient may have fleas and lice. And what I mean by that is you may have 2 different problems that can cause pain. It's the pain between the shoulder could be either a neck problem or a thoracic problem. Usually back pain does not radiate up the legs unless it's a very severe case, or there are rare instances if there is an infection that tracked down from the back and went up to between the shoulders, but that's unusual. That's very unusual. I would have her see her doctor and maybe investigate her neck or her thoracic area for the source of her pain. And we'd be happy to see her at our office if she wants to make an appointment offline, and we'll give information at the end of the talk of how you can make an appointment to come in and see us. Okay, next slide. Here we go. Us doctors are always trying to make simple stuff try to sound even more complicated, and neuromodulation is another way or another term to change the effect or behavior of a nerve. In this case, it's with a current that has a specific amplitude, pulse width, and frequency. It's to change the behavior of how the nerve acts. Even though it seems like a newer technology, it's actually been approved and in use for over 40 years. It's a non-drug therapy in so much that you're not taking a medicine every day, but I would think of the stimulator as a type of therapy or even like a drug, but instead of taking an addictive medication, it just runs on electricity or current. This type of neuromodulation is not only for pain, it also can be used for other diseases like Parkinson's disease is chronic, essential tremor, or even seizures, and it's also certain forms that can even be used to treat depression. So we're finding a wide array of uses to change the behavior of a nerve with stimulation or modulation. Fortunately, unlike some experimental treatments, this is considered non-experimental, and therefore it's covered by most insurance plans, Medicare, and even workers' compensation. And What's changing is not the concept, but like the technology in delivering the stimulation. So in the past, we gave what was called tonic stimulation, where you would feel it, you would feel champagne bubbles or stimulation going down your legs. The newer treatment modalities are sub-perception, so you can't even feel it when it's on, and they take time to wash in, several days to wash in. But with any surgery, there's always a risk that it may not work, or there's always a risk of complications, injury to a nerve, injury to surrounding structures, bleeding, or infection. So it should only be used if the pain symptoms are really interfering with your life and you're willing to accept the risks of the surgery. How does SCS work? So let's try to explain how this works. Well, there's a few different theories on how neuromodulation works. The basic theory that we first understood was a theory called gating. And the way I would think of gating is you don't have to be a neuroscientist or a neurosurgeon to know that if you hit your thumb with a hammer and it hurts, oftentimes it feels better if you rub your hand. And rubbing your hand gives an alternate source of stimulation to your brain and takes your mind off of it. Well, your mind gets smart, and after a while, sometimes you need to change the stimulation. And in these devices, there are hundreds of thousands of different combinations and programs that we can offer to change it up. So oftentimes after you get a device in, we'll change the program with a remote control. Other theories are affecting nerves or interneurons that are deeper within the spinal cord itself and interfering with their ability to actually relay the signal to the brain. That's the concept. But because pain is a very personal situation, it's an experience. It's not an event, it's an experience. Every patient that I will work on has to have a two-step operation. So it's a stage 1 and a stage 2. Stage 1 is putting in a temporary lead or temporary wire and just seeing if you like it. We let you walk around for 7 to 10 days, sometimes longer, just to see if you like it. I call this the try before you buy type therapy. And it's very easily reversible. If it doesn't work, we can easily pull the leads out, usually in the office. But if it does work, what we'll do is get more advanced studies like an MRI for surgical planning and actually put a real lead in your body permanently that does not come outside of your body. The biggest downside, I think, to the trial that patients have told me is, unfortunately, since the wires are coming out of your body during the trial, you can't take a shower or a bath. But that doesn't mean you can't keep clean. You still have to keep clean with like sponge baths. So don't come to my office really dirty and I haven't showered in 2 weeks because I'm on the trial. You should still try to keep clean and have good hygiene.
Dr. Braxton, we actually have a couple of questions for you if we want to take a second out for them.
Sure.
We have a patient here that is asking if neuromodulation could be used with pain associated with rheumatoid arthritis.
Rheumatoid arthritis generally is a more mechanical type of pain. The joint breaks down from an autoimmune process and it causes mechanical pain. And spinal cord stimulation is recommended only for nerve pain. The one caveat to that is if the rheumatoid arthritis is so severe that a bone has slipped out of place and has injured a nerve, and now you have nerve pain. But mostly rheumatoid arthritis pain is mechanical pain. Occasionally, rarely could it be a nerve type pain.
We also have a second question here. This patient has had a sheet of extremely tight muscles across the mid-back that has lasted for almost a year and limits motion. She's tried a number of minimally invasive procedures such as massage, acupuncture, chiropractic work, dry needling, so on, and nothing seems to have made a dent. She does have some minor arthritis, but doesn't feel like this is a mechanical pain. Do you think that this could potentially be a nerve issue?
Well, I would have to do a more detailed history and examination. Some people can get nerve type pain if there's a history of an infection and it's a viral infection, and usually the first time it comes on there's skin eruptions. That sometimes can be treated with a stimulator device, or sometimes with medication. Or if she's describing more of a tightness, it could be a myofascial type of pain syndrome, in which case I would probably send her to one of my partners to be considered for either cryotherapy, freezing the area, or possibly less conventional injections that are not steroids but maybe biologic nature. What do I mean by biologic nature? They might be platelet-rich plasma or even bone marrow stem cells in that area. This is a question that I may not be able to solve during this webinar, but I would encourage you to get an appointment and maybe to see myself, or even better, probably Dr. Nurki or Dr. Rob to do a more detailed explanation. And that might include X-rays or MRI or advanced imaging to take a look.
All right, I think that's it for questions at the moment.
So it's generally considered a 4-step process. Nothing happens if you stay at home in pain. It starts by scheduling a visit with your physician. And that could be Dr. Rob, Dr. Nurki, or myself, and just discussing what your options are and what we feel is the best way to go. Once you decide on trialing with the spinal cord stimulator, there's something that surprises some patients, is that I order a psychological test on every patient that comes to my office that is being considered for a spinal cord stimulator. You might say, well, I'm fine, I'm not crazy, why do I need a psychological test?
I already had that.
Yeah, no.
The purpose of the psychological test is just to make sure you don't have major depression or anxiety or some type of psychological issue that interferes with your ability to perceive pain, or on the other side, cognitive dementia that interferes with the ability to work the system. So we have to see if you're a candidate with a psychological test. Now, it's very common for people with pain that lasts more than 6 months to have some depression. I would be depressed if I wasn't able to interact well with my family or go out and do things that I enjoy. But as long as the depression is treatable, and if depression is secondary to pain, we generally can proceed with a trial. Once the trial is done, we have a meeting, and this is the most important meeting, because this is when the patient is in the driver's seat, and I can't say that a permanent implant is right because I can't feel the pain myself. The patient needs to tell me that they had improvement, and that improvement might be improved sleep, decreased narcotics or pain medication, decreased pain with at least 50%, and improved functionality, able to get back to your regular activities. And then we decide, we decide together as a team if spinal cord stimulation is right for the patient, and we proceed with the surgery. It's generally a 2-week process, starting with a trial and then the permanent implant at 2 weeks, but it doesn't have to be 2 weeks. Sometimes the patient can't make up their mind in the office, and that's fine, and we give them more time to think about it.
Dr. Braxton, we have 2 people who've raised their hands. I'm going to unmute them one by one and have them ask questions.
Okay, let's do it.
Bill, are you there?
Can you hear me?
Yes,
I
we
can hear you.
Would
We
you
can hear you.
Could you ask your question?
Okay. My wife has a question for you.
Yeah, I wanted to know if spinal cord stimulation would help. I have a sort of a combination of osteoarthritis and scoliosis. And so I have pain doing things like hiking, playing golf, riding my bike, and that sort of thing. If I sat around the house all day, perhaps I wouldn't have as much pain, but that's not the lifestyle I want. So would you think that spinal cord stimulation might help me?
That's an interesting question. So the question was, can spinal cord stimulation help a person with osteoarthritis and scoliosis?
Right.
It might be able to help some of the symptoms if it's nerve pain. If the pain is from a nerve, like a toothache, because when you get up and you move, the bone is pinching a nerve, it could help that. But if you're healthy enough, I would probably start by recommending maybe correcting some or part of your scoliosis and taking the pressure off the nerve mechanically. But this is a question that we've got to go into more detail and determine how bad is your scoliosis. Are you a good enough or healthy enough candidate for correcting the scoliosis? In some patients, if it's a nerve issue and they're just not healthy enough or not willing to go through the correction surgery, which can have a long recovery of up to a year, then maybe we can try a stimulator, and you don't really lose all that much by trying it to see if it works. Now, the osteoarthritis is almost always mechanical pain. The mechanical pain usually does not get better with this type of stimulation. It's only the nerve pain. We have to think of pain as two different flavors. And the mechanical type pain that's from arthritis, bone-on-bone grinding, that usually does not get better from neuromodulation. That might be better from either replacing the joint, if it's in a joint that could be replaced, or immobilizing that joint with what's called a fusion operation. So this is I can answer the question quickly and say maybe, but I don't know unless we try it and do a more detailed workup. That's because I don't want to steer you wrong, but possibly if it's from a nerve pain, but a lot of times osteoarthritis causes mechanical pain. And if it's from a scoliosis, sometimes a better thing, rather than using neuromodulation, is fixing the problem with a corrective surgery. Sometimes I like to think of spinal cord stimulator as wearing noise canceling headphones. Ever see those folks on the airplane with those big headphones over their ear? It's kind of like if you're on the plane and it's very noisy, you can't tell the pilot to turn off the engine because the plane's going to crash. So maybe the next best thing is wearing noise canceling headphones. You can still hear it in the background, but you might be able to rest or do other activities, concentrate, or so on and so forth. The stimulator does not correct the underlying problem. It helps block your perception of it. It helps make your life better with the noise canceling headphones. But if we could just turn off the engine, that might be better. So we need to have a discussion of what is the right thing for you. And that's something I can't really do on this webinar, as good as I am, is just by the sound of your voice and your question tell how many degrees of scoliosis you have, how much of this is mechanical, how much of this is neuropathic. You might need more tests. You might even need an injection to see if it is nerve pain. That's kind of a long answer to a short question. The short answer is maybe.
Dr. Braxton, we have another person that raised their hand. Would the Galaxy S10 user please feel free to speak if you could?
I like Samsung phones. I have one myself.
Are you there?
You got to unmute yourself.
We'll move along. We've got another chat question here. Where do you go when you've tried everything you have mentioned, including a fusion surgery, and MRIs do not show anything specific?
That is kind of collectively termed a syndrome called failed back syndrome. So you've tried surgery, you've gotten MRIs, and it's pain that's lasted 6 months. That's usually a very good candidate. Although I'm not practicing medicine on this webinar, I'm just telling you what I know, that it's a lot of instances is a good candidate for a spinal cord stimulator. And I've had many patients come to see me who've seen several different doctors and said, there's nothing more that can be done. That's the time where I think doing the trial to see if it helps is a good idea. That's called failed back syndrome, when you've had surgery and you continue to have symptoms, you've been reevaluated and been told there's the MRI doesn't show anything. Now, as part of completeness, I won't just take your word for it. I'm going to want to see the MRI myself, examine you myself, get x-rays myself to make sure there's not something I can fix, an easier fix than using the stimulator.
I think we're good to proceed. I don't have any other questions at the moment.
All right, well, we're coming up to the end of this. And these are maybe the more important slides to kind of get to know if spinal cord stimulator worked, if the trial worked. Well, we look at a number of criteria. We're even getting into the modern age. I asked all my patients, and you guys can do this at home, or you can do it in the office when you come and see me, is you can go to, if you have a Samsung phone, the Galaxy S10, you can go to the Google Play Store and type in My SCS. That's MYSCS, and there'll be an app where you can get more education and more information. If you're an Apple user, like my wife, who I think is listening out there, I love you, you can go to the Apple Store and type in My SCS, and it's an app. Now, this app is 3 parts. One, it can help you communicate with Boston Scientific to see if you're a candidate and get you connected with me. 2, it can give you information and education of learning about other patients that have had it, how it works, some of the things that I talked about today. And 3, the most important, is after you get the trial, it helps you record your pain and keep what we call a digital pain diary. A digital pain diary is nothing more than a pain diary of, well, these are my goals. This morning, I tried programs 1, 2, and 3, and I was able to walk twice as far as normal. Or I didn't have to get my 12 o'clock dose of pain medication, or my sleep was improved. And it helps you memorialize it, because sometimes when you're in the office and all the lights are on you, and I say, well, did it work? And you get stage fright, and you're like, I'm not sure if it worked. Well, I'll look at your phone, your app, and I'll get a printout, and I can say, well, according to this, you were able to get back to more of your daily activities. You were able to spend more time playing with your grandchildren or children. You were able to get more sleep, and your pain, according to this, is 50% reduced. Based off of this, I think you might be a candidate for a permanent implant, or it might be a different story that it didn't work. The success rate is quoted in the literature is around 70%. I think my success rate is maybe hovering around 80%. And I can't say why that number is different, because I do the same technique as other doctors do, but maybe I'm a little bit more selective on who actually should get the stimulator and who actually needs a surgical correction, and I spend a lot of time trying to ask you a lot of questions, because you're going to tell me if it's nerve pain or mechanical pain, but it's going to be through my questioning, and I'm going to ask you a lot of questions, and it's in a lot of questionnaires, look at a lot of imaging to determine if I think this is mechanical pain or nerve pain, and we'll work together as a team.
We actually have one more question too. It says,
sure.
What do you think of gabapentin for stenosis?
That's a good question. So gabapentin is probably one of the more common medications I prescribe. You guys may not know this, or maybe you already do, but gabapentin is FDA approved and is originally designed to be a seizure medication, like for epilepsy. And what seizures are abnormal synchronous electrical activity in the brain. And what gabapentin does is it slows the transmission of a seizure that's kindling in one part of the brain and spreading to another part of the brain. Well, it turns out that gabapentin is actually not the best seizure drugs. There's a lot of other drugs that are superior to gabapentin, and gabapentin is rarely used to treat seizures. And in my 15 years of practice, I've never come across a patient who takes gabapentin for their seizures. But we did find as a side effect that it has a good effect on neuropathic pain. So the difficulty with gabapentin is its bioavailability, meaning only a small amount of the drug is actually working in your system when you take it. That's why if you're going to take it, you've got to take it on a schedule and 3 times a day. And if you're going to take it, only about 30% of that gabapentin is actually bioavailable and doing its job. So therefore, dosing is kind of challenging. So we usually start patients off on a low dose and titrate them up to a higher dose. A newer drug, which happens to be more expensive, is pregabalin, or Lyrica. And that is 90% bioavailable, and so the dosing is easier. It may help with claudication, but it's not approved to treat that indication. But doctors may experiment with that to see if it's nerve pain, because gabapentin generally will not help mechanical pain. It generally only helps nerve pain, but it's not an improved treatment, and there's not a lot of level 1 data. Level 1 data is the best type of evidence that you can have in medicine. It means a randomized controlled trial with placebos, and one group gets a sugar pill, one group gets gabapentin. We don't tell them what they got, and we see if they got it. Those types of studies have not been done for neurogenic claudication. The doctor may try it, it may help. I would recommend trying to treat the underlying cause, which is an outpatient decompression. Probably. There's other devices that can be done as well, such as interspinous fixation devices. I know a doctor that does those, and I can send you to them if you're more interested in that. But I would consider going to the source. But it might be a good diagnostic tool, or just help you get through surgery, the surgical dysesthesias that you have after surgery. I would say it's not a good long-term fix for neurogenic, for spinal stenosis, but it might ease it up. Hopefully that answers that question. It's really a seizure medication, and it's not designed to treat stenosis. Okay, I'm gonna keep on going. We're getting close to the hour mark, the witching hour. So the interesting thing about this device is you can direct it to different parts of your body. It's very unusual that way. So you could turn on a program that is directed towards your feet and just your left foot, or you can put on a program that just goes just to the left side of your back or just to the right side of your leg. So it can change over time, and you can use different programs. And since sometimes folks have progressive diseases and it changes. I personally have a patient who I put the stimulator in for terrible left leg pain. I put this in several years ago. Left leg pain became much better and almost went away. And then she came in several years later with right-sided thigh pain. And I thought, rather than trying to do another surgery, another operation, why don't we just see if the stimulator can cover the right thigh? And so in that way, it's very versatile, and you can move it to different parts of your body. That's what I found so fascinating about spinal cord stimulation is it really depends exactly on where you put it and on what program you're using. And there's different types of programs. There's the tonic type program where you can feel it. I call it the champagne bubbles in your legs, kind of that bubbly, tingly feeling to kind of block your pain. Or they can do paresthesia-free programs where it's sub-perception. It's working at such a high, it's like a dog whistle. It's at such a high frequency, or we call hertz, that you're not able to perceive it, and it's working on a different part of the spinal cord. Or you can do a combination of those, or you can alter them. So there's a lot of different versatility there. All right, I'm going to move on to my next slide. Okay, so when I was talking about the level 1 evidence, the long-term outcome scores, this is an example of one such study that was done that showed a decrease of pain from an 8, which is usually pretty terrible, unbearable pain, to a 2 or a 3. This is saying 3. Usually with a 3-level pain, it's not gone, but you can still do your activities. And this is durable relief that's lasted up to 2 years. In a large clinical study. And this is how these devices get approved to be proven to be safe and effective. So when you come up with a new medical device, there's 2 hurdles. You got to prove that one, that it's safe, it's not going to cause a problem, and then 2, that it's effective, that it really does what it's supposed to do. Now, I didn't say the pain was 0, but the pain is more manageable, and hopefully that during this process, you can get yourself off the narcotics. And we talked about in the very beginning that narcotics, besides making you constipated and sleepy and missing out on life, they can be very addictive, and you can overdose on them because you need more and more narcotics the more you take it. So that's what I wanted to show in this slide here.
We have 2 questions again, if you're ready for another question.
Oh, hit me with your best shot.
All right, we have a question. Does Cymbalta work for any kind of pain or just nerve pain?
So Cymbalta remember how I said gabapentin is really initially designed for seizures? Cymbalta was initially designed for depression. But when we do these studies, we'll give a test group the medication, and we'll ask them to write down what was going on. And we noticed as a side effect that nerve pain seemed to improve it. But its main function, its main role is in treating depression. But as a side benefit, it can help with nerve pain. Cymbalta is not really designed to treat mechanical pain. Mechanical pain is usually treated with things like Tylenol, non-steroidal anti-inflammatory medications. That's a fancy way of saying ibuprofen or Aleve. And in some cases, mechanical pain can be treated with opiates on a short-term basis. I wouldn't recommend treating a mechanical problem with opioids for more than a week or two because of the negative side effects. So very short-term basis. Now, different story if we're talking hospice care or cancer pain. Then we decided that the risk of overdose and long-term problems isn't as great as the threat of the cancer pain coming on. So that's more of a palliative situation. But to answer your question, Cymbalta has a side effect of treating nerve pain. And it kind of brings me to an interesting topic. How come there aren't a lot of drugs designed to treat nerve pain? And that's a very good question because it affects so many Americans. I think that most of the drugs are designed to treat, that we use to treat nerve pain, are really designed to treat something else, and the side effect is the side benefit is treating the nerve pain. I'm going to tell you one interesting story, and this is a medical story, is that you may have heard of the drug Viagra. Well, Viagra was initially designed to treat blood pressure. And they gave it to test subjects, and they said, "Doc, it didn't help my blood pressure, but it did something else." So we sometimes find different uses for drugs when they're designed for something else. And I just think that was a funny thing about medicine.
Dr. Braxton, there's one more question too. This patient is asking, are any of these new treatments recommended for cardiac rehab patients with lumbar spinal stenosis?
So that's an interesting question. So this talk needs to be, on label, and in the United States, it's not used to treat cardiac pain. But I can tell you, in other countries in Europe, it is sometimes used to treat cardiac pain, but it would not be done in the United States. But it can be used to treat. The question was, can it be used to treat spinal stenosis pain? The answer is yes, but it's a more nuanced question. I would, if the patient is healthy enough, assuming their heart was strong enough, I would try to do an awake outpatient decompression, or send them to a doctor that can open up, that can put in. I can do it too. I just prefer to do the decompression. There are other devices that could go into the spine to open it up as well. If you're healthy enough for that, that might be better than doing the stimulator, because I said the stimulator has been shown to take the pain down from like a 7 or 8 to a 2 or a 3, but you might be able to hit a home run with a decompression. Now, if your heart is so tenuous, and all the doctors, whenever you get up, they're putting their hands up like, oh my God, this guy's going to have a heart attack at any minute. Maybe a stimulator might be a palliative option there. But I would try first to treat the underlying problem with the decompression, which is what I talked about earlier, as opposed to doing a stimulator. But there could be special circumstances where we don't even think the patient could lay still for half an hour or 45 minutes. We need to do a really quick stimulator operation, which can take around 15 to 20 minutes, depending on the anatomy, for the trial. The implant for me takes a little bit longer, around closer to an hour to do. But this is a more nuanced question. But again, the answer is maybe. But in the right patient, maybe. But I would, just hearing it, try to just fix the stenosis. And in the United States, we can't put in stimulators for cardiac pain. That you would have to go to another country for that, like France or Germany. It's a first world country, but that's where they do that type of stuff with the stimulators for angina.
Dr. Braxton, there's another question here too. Is COVID a consideration in holding off, basically, in doing any of these procedures or the spinal cord stimulator?
So again, a nuanced question. if you asked me that question in March when we didn't really understand what was going on with COVID, or April, I would say yes, because I did 0 stimulator cases in March and April. But now that have it in our community, our local community, under better control, I would say not necessarily. The risks of getting it in our local community are lower. Now, if this caller is calling from a hotspot, say Houston, Phoenix, Arizona, Tampa, Florida, maybe you want to hold off. And I leave that to local public health officials. But currently, we are doing stimulator cases right now because the restriction on elective surgery is relieved. But March and April, I'd say no, you need to wait. You'd have to wait. But now we're doing cases, and it's got to be on a case by case basis. And if you're one, it's the patient psychology. If there is a firm fixed fear or anxiety about getting it, I feel that anxious patients don't do as well as patients that are more relaxed about it. The other one is if you have a lot of these comorbidities that put you at really, really high risk, I wouldn't do it. But I do these in the surgery center, and we don't do any COVID cases in the surgery center. Everybody's screened in the surgery center, and it's separate from the hospital where somebody who may have COVID may end up in the hospital. But I'd like to do these outpatient in the surgery center. So I'd say the risk is acceptable. I can't tell you exactly what it is, but it's low enough that I am now doing stimulator cases now. Now, that could change. I don't know what's going to happen in the winter months during flu season, because it's going to get harder and harder to tell who might have COVID and who might just have the flu. We're going to have to do more testing. We have a lot of tests now, but we could run out of them pretty easily because there's a demand all across the not the United States, but the entire world for these test kits. So for the month of September, I'll say yes. The future, I don't know. Definitely not in March or April, and it depends on where you live. Does that answer? Hopefully that answers that question. I know I'm not answering the question directly. Like, just give me a yes or no, doc. I can't, because it's a more nuanced question. Okay, so this talk is not meant to diagnose or treat any condition. It's mostly for education, and mostly hopefully to make you aware of other options that you may not have heard of. I wish I could see everybody's faces and do a show of hands how many people have even heard of spinal cord stimulators. And I would say probably the majority. Don't feel bad if you've never heard of it, because probably the majority have never heard of neuromodulation, and that's okay. And that's part of this talk, is to make what I call therapy awareness. Just make you aware of different therapies out there that you don't, even though you've been taking narcotics for the last few years, you may want to consider a change because of the risk of overdose or the risk of addiction or dependence, plus the other negative side effects of feeling sleepy all the time, missing out on life, and the constipation, I think, is the worst with the narcotics. If any of you guys have been on it, I'm sure you will agree that a lot of these narcotics can make you very constipated, which sometimes is worse than the problem. So I have a website called braxtonmd.com, pretty easy to remember. And the other website that is run by Boston Scientific that can give you more information is called controlyourpain.com. And our website, if you want to get a hold of Dr. Nurki or Dr. Rob for radiofrequency stimulation, I'm sorry I don't have it written down here, but it's called vsortho.com. And again, this talk will be rebroadcast as soon as I can get Rachel to edit it and put it online, probably in a few days.
Dr. Braxton, I think we have one last question here. It's, is there a problem doing decompression or stimulation if one is on blood thinners?
I can answer that question. The answer is yes, but we have solutions. So it's very dangerous to do a stimulator trial if you're on blood thinners, because you can get what's called bleeding or hematoma on your spine, and it could, in some certain circumstances, result in a permanent disability or even paralysis. So we need to make a window of getting you off of it for a short period of time to do the stimulator or the decompression. Generally, for my decompression cases, I'll take them off the blood thinners for a period of time of several days to a week, depending on what type of blood thinner it is. There's a lot of different kinds. It's a whole alphabet soup of heparin, Xarelto, Eliquis, Coumadin, Lovenox. There are many different types of, and each one of them has a different time period that you need to be off of it. I'll do the surgery, and depending on what the reason that you're on the blood thinner for, I'll restart it a few days after. Sometimes I'll start it the next day if you have a really, really good reason, like I need to be on this blood thinner or I'm gonna clot off my stent. I'll start it really quickly. But if you're like, I need this blood thinner because my doctor told me I have a slightly increased risk of stroke because of a disease called atrial fibrillation, I might leave you off of it for a few days because your risk of getting a stroke during that window is very small. The stimulator one is a little trickier because remember I said it's a two-step operation. It's 2 stages, a trial and the implant. So you need to be off of it for a longer period of time, for 2 to 3 weeks. So we need to talk to the doctor that starts you on the blood thinners and understand the reason why and gauge your risk for being off of it. But you have to be off of it during the surgery. And a lot of medicine, and frankly, a lot of life is risk stratification and risk control. So we look at the risk of the consequences of being off the blood thinner. Maybe it's a blood clot in your lung called a pulmonary embolus. Maybe it's a heart attack or a stroke. Or maybe it's something else, like a stent that another doctor has put in that they want to keep open and they don't want it to clot off, versus the potential benefit from the intervention, which is a decompression or a stimulator or what have you. And we just have to make a risk. And sometimes I say, listen, there's a chance you could have a stroke. I think it's small. I think it's about 5%, 2%, 3% based off of your risk stratification. Are you willing to accept this risk? Because in the end, the patient has to accept the consequences and the risk, and I try to guide them through that process. So the answer is yes, you have to be off of them, but it doesn't mean you can't get the therapy. I do cases all the time on patients on blood thinners. We just have to stop it and then restart it based off the reason why they're on it. And this is something that is best discussed in the office and probably with your other doctor that started you on the blood thinners. So that was a great question. I really like that question. So I've talked a lot during this thing and during this event, and I'd like to thank Rachel from our marketing department, Craig from Castle Peak, and Rand, who can't speak today, and Leslie for helping me put all this together. I can't do it by myself to get this message out. We'll try to do more of these on different topics. Let us know when we post a video what other topics you'd like to hear about, and we'll try to have an expert talk about that for a bit. We're planning to do one at the end of October about SI joint pain, which is we'll talk about that later. But that will be the next one that I'm planning to do, is a talk on SI joint pain. If there's no more questions.
I think there's one last question, Dr. Braxton. I'll just do this last one. She's been waiting for a few minutes.
Sure.
It's just a question with if you have a new pain area, such as a thoracic pain, would you recommend MRIs of the whole spine just to aid in the diagnosis?
Not necessarily. I mean, so there's a little bit of like, we as physicians, we take care of the patient that's in front of us, but we also take care of our whole flock, and we try not to order unnecessary tests. If there's not a sign that there is a lumbar issue, then I wouldn't order the lumbar MRI, mostly because of cost, but also it is an inconvenience to the patient because an MRI of the thoracic spine could be more than an hour or multiple hours, and it's a small tube to be in. So I try to use my brain and use my ears by listening to the patient to figure out what is the highest yield or most likely incidence where we're going to figure out our answer. So I think doctors that order MRIs of one area are the smarter doctors. If you really just don't know what's going on, you might order an MRI of the entire neuroaxis. That is generally helpful in a few cases. And the one that comes to my mind is in the case of cancer, because in the case of cancer, you might be symptomatic in the thoracic spine, but we want to look it through the whole body. to see if there's any other cancers anywhere else. So the case of cancer is kind of an exception where we may look for what's called drop metastasis throughout the spine and order the entire spine. But in general, we try to focus in on one area, and that's one, it's better use of the patient's time, and it's better for the entire system that we're not wasting a lot of unnecessary tests and unnecessary studies that are not likely to show anything. And the best way to figure that out is by using the most important tool that a surgeon can have, which is your ears, listening to the patient.
All right, I think we're finished with questions this evening. Again, you guys will all be getting additional emails that'll have information on how to contact Dr. Braxton or the folks there at Castle Peaks. And you could also learn more on any of our websites that will also be listed on that email. So thank you so much for attending this evening. And thanks to Dr. Braxton and Craig for attending and speaking this evening. We really do appreciate it.
Thanks, y'all.